Good evening, and welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Miguel Quiñones, the editor-in-chief of the journal. And the current issue of the journal is on the exposome and cardiovascular health. For those of you watching who are not familiar with the term exposome, what it means is a description of the environmental exposure that individuals and populations have and how that exposure impacts biology and health. In our own interest is, of course, cardiovascular health. So this is a kind of a new evolving area of research. Up to maybe before 10 years or so ago, as physicians, we took care of patients and basically were concerned with their actual health, with prevention using current guidelines and giving medications that are appropriate and so on. And really, we're not paying attention to all the environmental factors that are so important in the health of a given person. This topic now has really moved up in importance, not only within the scientific community, but also within physicians, within social workers, within society in general, and in fact, even as you are aware, has impacted even current politics. So this is a very important evolving topic, and we feel very proud of the way this issue came up, because now you can come to one place and learn a lot about all the research and all the new knowledge that's being obtained in the impact of the environment in our health. I'm indebted to the editors, the guest editors for this issue, Dr. Khurram Nasser, who is the Winters Family Distinguished Centennial Chair and also the head of our Cardiovascular Prevention Division within the Heart Center. And sitting to my left is Dr. Sadir Al-Kindi, who is the Gerald Katz Translational Investigator at Houston Methodist DeBakey Heart and Vascular Center. Dr. Al-Kindi is going to pretty much carry the rest of the hour because Dr. Nasir had a very important family activity with his daughter that he had to participate. So we gave him permission to do that. So without any further delays, Sadir, thank you for being here. Take it on. And I'll be watching and maybe asking a few questions.
Thank you, Dr. Quiñones, for the opportunity to co-lead this special issue that's near and dear to my heart. This is an issue that really is outside the clinic, right? It's something that it's different from the prior issues that we've had in the journal and primarily in the literature of cardiovascular disease. So this is an issue that's special, that deals with the totality of environmental exposures and social exposures. And I'm really happy to have 4 distinguished authors in the journal here with us today to have a really a nice and deep discussion about issues that are related to the topics that they presented and topics that are related to the issue of the journal. So today I'm honored to be accompanied by Dr. Sanjay Rajagopalan, who's been my mentor and my friend. He's the chair of cardiovascular medicine and Herman Hellerstein professor of cardiovascular research at Case Western Reserve University in Cleveland, Ohio. I'm also accompanied by Basil Daher. Dr. Daher is an assistant director at the Energy Institute for the Sustainable Development at Texas A&M Energy Institute. We are also accompanied by Dr. Jay Maddock, who is the director and Regents professor at Texas A&M School of Public Health and the director for Center of Health and Nature at Houston Methodist and Texas A&M. And we're also accompanied by Andrew Macker, who is a student at Boston University. All of these distinguished authors contributed to the issue and the success of the issue. So welcome everybody, and thank you for taking time of your busy lives to join us today to have these discussions.
I just want to make a couple of comments. One is for those of you who are joining us, what we would like to achieve with this 1-hour webcast is to give you a taste for the importance of this topic, and hopefully you will learn a few things tonight, but hopefully you will be encouraged to actually pick up the journal online and be able to really read through it, because in 1 hour you cannot cover the whole topic and as comprehensive as it was when you read the articles. For those of you that may have any questions, feel free to text them to us by texting DeBakey to 37607.
All right, so we'll start with Dr. Rajagopalan. You've put really a masterpiece to kind of encompass the impact of air pollution on cardiovascular, kidney, and metabolic disease. So I'm going to ask you a more general question that was covered in your paper. But could you maybe debrief us about the impacts of air pollution specifically across the spectrum of CKM disease, and maybe talk a little bit about what we know about the potential mechanisms for that impact?
Thank you, Dr. Al-Kindi. Really a pleasure to be here, and congratulations to you and Dr. Nasir. Together, a very comprehensive review on a topic that is so important. And as you started off by saying, and as Dr. Quinones acknowledged, the oversized effect of the environment on human health has sort of been acknowledged for a long time, but it's only now that people are starting to pay close attention to the outsized impact of these multiple exposures are on human cardiovascular and health in general, and cardiovascular health in particular. So congratulations on this wonderful issue. So to your question, I think air pollution obviously is a very complex entity. It is comprised of thousands of chemicals that change spatially as well as temporally. In other words, they change in composition over time. And essentially the way people have sort of measured air pollution is by measuring the particle suspension in the atmosphere, and they've quantified this using the weight of particles, which are again fractionated according to size fractions. And why is this important? Well, the smaller the particles, and the particles again are suspensions of liquid as well as chemicals that you inhale, and the smaller the particles there are, and one of the common fractions that we are particularly interested in is PM2.5, or particle fractions less than 2.5 microns. And these particles are important because they penetrate the inner airways and often find their way into the circulation of the human body. And thereby, one of the pathways through which they are believed to exert their effect is through direct translocation. In other words, they leave the lungs once you inhale the particles to your systemic circulation, and then they go to different parts of your body. And it's for a long time now, people have detected air pollution particles, let's say in your brain or in your heart or other portions of your, in other organs in your body. And that's one of the direct ways in which pollution might mediate effects. Besides that, there's also other mechanisms by which air pollution can modulate or cause people to suffer from an excess of cardiovascular events. And some of those mechanisms happen to do with inflammation, where once you inhale particles, they induce inflammation and oxidative stress, and these mediators are released in the systemic circulation. So in general, it creates a systemic inflammatory state. Finally, there's also reason to believe that these particles can activate neuronal connections or nerves, tiny nerves in your lungs that go to your brain, and thereby might regulate things like blood pressure. And quite fundamentally, air pollution could also cause the very risk factors that we recognize to be important in cardiovascular disease. So this includes air pollution effects on blood pressure, and you've done a lot of work on these areas as well that people should know, as well as how air pollution can modulate and combine with other exposures in order to create heightened susceptibility for cardiovascular events.
Thank you. So this is now we understand that the air pollution has been kind of studied for decades and with work primarily, by your group and others. But now we know that air pollution is causal in the pathway of cardiovascular disease. What do you think about the policies that may lead to changes? What is the impact of policies that may lead to changes, whether increases or decreases in air pollution levels? And how do we view this within the context of health in general, but more specifically within cardiovascular health?
Oh, a great question. I think for exposures like air pollution or things in the environment, there's a fundamentally important role for policy, right? Because these are exposures that people are not responsible for. They're not in control of these exposures. So there's a critical role. And that's one of the reasons why physicians often feel that they're not in control. They don't need to talk about patients about air pollution because it's not within their control. It's not like they can give a pill for this, right? So policies are critical, and they are key aspects of policy decisions that play a fundamental role. And in this country, we know that in 1970, the Clean Air Act, which was during Richard Nixon's presidency, was instrumental in averting a very calamitous situation at that time, which was multiple episodes of air pollution smogs in several states, notably in a city called Donora in Pennsylvania. So there have been very bad episodes of air pollution in this country. And now there's the issue of wildfires. So policy can play a role in 4 or 5 different ways. The first way is to setting an emission standard. In the 1970, the Clean Air Act was responsible for promulgating the first national air quality standards, which was an act passed by Congress, and the Congress then enabled the Environmental Protection Agency to enforce those emission standards to ensure that various industries, as well as automobile manufacturers or various polluters, are adhering to certain standards. But even before that, to set standards that the states could then implement. So nationally, the federal government set these standards, and then implementation is up to the states. The second is enforcing compliance, and that goes back to what I mentioned about enforcing these standards locally, either by states or local authorities. Finally, the last 2 measures are critical these days, which is, in this country at least, we've seen a sea change in air pollution levels. We no longer are experiencing, other than wildfires now, these bad smog episodes, thanks to policy. But now we are in the brave new age of climate technologies and clean technologies and transition to clean energy sources. So incentivization of these technologies are clearly important. Now, this is a very political debate, obviously, where, with the change in government now, there's a whole debate about whether or not this transition to clean technologies will continue to evolve. And this is going to be critical in terms of improving air quality, at least in this country, even further. Finally, at a personal level, for physicians and for caregivers and for our patients, awareness is clearly important, and having very clear education campaigns, as well as providing the right information to patients. And you and I worked together with our colleague, Dr. Brook, on several papers in this regard, and you're quite familiar with this because you've written about this, which is how do you educate the public and provide them credible tools that are based on evidence. And right now, unfortunately, I think most of the air pollution warning systems that we have, or warning, the public guidance that's provided, is somewhat flawed, and it's not really based on evidence. And this is critical because once you give a public, you have to provide them guidance that's based on fact, so that they can protect themselves and take appropriate actions to reduce exposure.
Right. So, besides or in spite the progress that we have had in last 20, 30 years in reducing pollution, we still have it. And whenever I meet somebody for the first time and they start sneezing, I always say, welcome to Houston. Because we still have here in Houston a fair amount of air pollution that creates allergies and whatnot. So I'm going to ask you a crazy question. Is there any potential future room for developing vaccines against these particles?
No, it's not.
Is that something that is that
question.
Science fiction, or is that something that potentially could be thought of?
No, it's not a crazy question at all. I think we are in the brave new world of vaccines for everything, right? So we have hypertension vaccines, not at all inappropriate. But what I would say is more of a primary, I guess, responsibility as well as response would be to reduce air pollution to begin with, right? So what you're alluding to is, there might be levels beyond which it might be very hard to reduce air pollution further. So if you look at the air pollution response curve, Dr. Quinones, there's no lower level at which air pollution is safe. So it's almost like radiation, right? So, and radiation we know is as low as possible. So air pollution is also as low as possible. So there might be limits at which you need societal sustenance, and to just keep societies humming and living, you might need a certain level of exposure. You might need certain levels of fossil fuel sources, at least in the foreseeable future. So what you're asking is, in order to mitigate that risk even further, the first thing you have to do is reduce exposures. But given the fact that there might be limitations in society to go beyond certain levels, would there be opportunities in vaccines? Possible. But I would say the compositional characteristics of air pollution is so dizzyingly complex. And most vaccines, as you know, are related to certain very specific protein epitopes.
Right.
It might be hard, but on the other hand, it might be possible to vaccinate people with a gamish of air pollutant mixtures, I suppose, and create, a robust antibody response. So possible, not crazy.
Well, thank you, Dr. Rajagopal. And I'm going to turn it around to Dr. Daher, who's the Assistant Director for Sustainable Development at Texas A&M Energy Institute. And I'm going to ask him, he wrote a fantastic sole author review of on food for thought and cardiovascular exposome. I think he's probably the only one. Maybe there's a couple papers in the journal now that are sole author. But Dr. Daher spoke about food for thought, nourishing the cardiovascular health amidst the exposome. So Dr. Daher, I want to ask you about, how do you view the food exposome or the food environment, and then within the context of dietary changes and dietary guidelines that can influence health in general and cardiovascular health in specific? Could you please comment on that?
Thank you very much, Dr. Kindi, and thank you for inviting me to this very interesting webinar and very, very useful, very timely. The exposome context or concept, with its emphasis on the totality of the environmental exposure and lifestyle factors, provides a very valuable framework for understanding how all of these diverse elements interact to influence health, and specifically cardiovascular health over lifetime. And diet, as we saw in the paper, is well studied angle or aspect of the exposome, and recognized as a critical contributor to cardiovascular health and impacting and influencing various other health metrics and behaviors. And in fact, as part of the American Health Association's Life Essentials, 7 or 8 essentials, diet was mentioned as one of those life essentials, including cigarette smoking, body mass index, physical health activity, etc., among different contributors to cardiovascular risk. So in this review paper, I specifically looked at the interconnections between the exposome and cardiovascular disease through the lens of agricultural systems and environmental health, while examining the influence of socioeconomic and cultural factors on agricultural food systems and dietary choices. And to answer your question about guidelines, so there was a lot of studies and a lot of literature and guidance in terms of recommendations that specifically encourage consumption of minimally processed foods and whole foods and fruits and vegetables and whole grains, etc., antioxidant-rich foods, and recommended to avoid saturated fats, trans fats, processed, ultra-processed foods. So the direct influences of diet on cardiovascular health are clear, and there are many guidelines and examples, and popular diets like the Mediterranean diet stand out as one of the more heart healthy diets out there. But we need to understand that as we look at diet is embedded in different systems also, and as the choices, dietary choices that people have are impacted by different socioeconomic status, cultural preferences, food availability, marketing, labeling, that influence those dietary choices, and those also are embedded within agricultural systems, which also have an impact directly and indirectly on cardiovascular health and on environmental health, which in turn has its feedback effect on cardiovascular health. So I think the relationships between diet, agricultural practices, environmental health, cardiovascular health, which were illustrated through different evidence in the literature throughout the paper, highlight the need for a comprehensive systems approach to improving cardiovascular health outcomes. And once we understand these many interconnections between the environment, agricultural system, dietary choices, and their impact on cardiovascular health, we can better identify critical root causes for cardiovascular disease or different interventions that would allow us to unravel new opportunities for improving cardiovascular health, which shift from reactive to preventive healthcare and again addresses some of these root causes of cardiovascular health rather than focusing on a lot of the symptoms.
Yeah, that's exactly right. And I think that one key theme here is that environment impacts dietary choices, and dietary choices can also impact the environment. And all of that sits within the planetary health kind of boundaries that really can impact health across the board, from animal health to human health to planet health in general. So I'll ask you, you mentioned that environmental health and socioeconomic status can impact dietary choices. How do you view, food environment specifically, food security, and how do you view the factors, the socioeconomic and environmental factors, and even cultural factors in deciding dietary choices for individuals?
Yeah, certainly the decision to choose a diet is not in vacuum, is not happening in vacuum, and it's part of different, again, environmental, social, cultural systems that all play a role in impacting what people end up dietary choices that people end up making, and some of the environmental determinants that affect cardiovascular health, which emerged from the literature as part of the paper, included air pollution, chemical and pesticide exposure, which usually is attributed and the result of agricultural practices like monocropping, heavy pesticides use. There was also a lot of work done on over-tillage and how it depletes soil, and also with heavy pesticide use, pollution of water, reducing availability of nutrient-dense foods, affecting soil health, which in turn affects the quality and the nutrient quality of food. And that's in addition also to socioeconomic and cultural influences that affect dietary choices, which are impacted by the cost of food, the affordability, the availability, the convenience of food, which and its influences on what people eat, the education on around food and nutrition, which is not always available or accessible to people to allow them to make better informed decision about more heart healthy or healthy foods in general. So that limited the food and nutrition education and marketing practices that usually we see reinforcing unhealthy dietary habits. So the reflection here is that it's again important that we adopt a systems approach to cardiovascular health by understanding all of these influences and determinants of the exposome. And once we understand these interconnections and optimize a food system that currently is mostly optimized for maximizing yield and profit, to include other metrics that include better nutrition, better health-related impact, which is not necessarily what we see today, especially when we look at again many of the practices that I mentioned earlier, resulting from monocropping and industrial animal farming, etc. So again, all of these are tightly interconnected, and unless we understand those interconnections and look at that at them holistically, we won't be able to address root causes for cardiovascular disease and take advantage of new opportunities to improve cardiovascular health.
Yeah, and I think part of the systems, right? You mentioned the systems a lot in this discussion. I think what happens when we start disrupting the system, right? And we're talking specifically about policies, right? When we human can disrupt the systems that may impact, dietary changes or food environments, and with or without thinking about health as the core. Can you recall some experiences or examples where policies can either positively or negatively impact food environment, dietary choices, and downstream cardiovascular health?
I am aware of a couple of federally funded programs which focus on nutrition assistance. So SNAP, the Supplemental Nutrition Assistance Program, which provides food benefits to low-income families to supplement their groceries with more nutritious food that they otherwise wouldn't be able to afford. So I think that such programs could play a role in allowing or improving the accessibility and affordability of some of these more nutritious foods to people. But in addition to policies, I think there are several levers that could be used to accomplish that. So one is policies and through different programs that could provide better access and better affordability for more nutritious foods. Another could be through education. I think also is key and is key to behavioral shift or to better informed diets and food choices that are good for our health and for our planet's health as well. And I think I don't see a lot of work that has been done on that yet, but it would be interesting to see the sensitivity of people's choices to food products once they are more aware of the impact of those foods on their health and on their planetary health, and to see if people are presented with two different choices and they are aware of the impact those have on their health and the planet's health, would their choices differ or would be affected. So again, I'm going back to the emphasizing the importance of education and making that information available, but then also aligning that with incentives that could maybe nudge people to making better choices that have better cardiovascular health and health outcomes more generally speaking.
This is a topic that is clearly gaining a lot of interest in the public. And as we all have heard recently, there is also a lot of interest in this whole issue of food contamination with chemicals, and trying to go more towards more natural foods than the ones that are potentially being contaminated with different chemicals. How much of this is really true and factual and important versus just something out in the news? And if it's important, because patients are beginning to ask us now. They come in and ask us about this, try to get our advice. And one of the problems is that the more pure natural foods that we all can consume also tend to be more expensive.
Yes.
So the people who are in these food desert environments really end up having access just to the other kind. So I think this is one of the areas that is gaining a lot of interest, even in the political arena. So what are your thoughts about it? What should we be telling patients?
I think this goes back to Dr. Kindi's question about policies, and I think this is where incentives or subsidies should be put in place to support having more affordable, healthy food, which is not the case. So the reason we have a much cheaper burger than a salad today is because of the subsidies we have for that support for producing that cheaper product that is again resulting from a system that is very much predominantly relying on monocultures and all of these industrial agricultural activities. So that needs to be taken into account as we look at subsidies and at incentivizing farmers to produce things differently, which they currently are not.
Miguel, if I may just add to Basil's comments, another huge problem that we often fail to recognize is the industrialization of agriculture and a profound transition to elimination of biodiverse foods, right? So if you look at it in the planet, 50% of the world's calories are provided by 3 grains: rice, maize, and wheat, more than 50%. Out of 250,000 edible plants, we probably consume 200, but more than 75% of the time, we use something like 8 plants and 4 or 5 animals for our diet. Right? This is a profoundly, if you think about it, the massiveness of which we've transitioned to very simplified diets and agricultural systems that use nitrogen and phosphorus fertilizers that permeate our water streams and just completely eliminate the biodiversity of soils is so profound that it's staggering even to start thinking about. And this has been going on for a few decades now, right? And these are questions that we'll have to grapple with and maybe find new ways of investigating the effects. I don't know how you do it or how you would design a clinical study to examine this, but these are massive, massive shifts.
Yeah.
If I may add also, I mean, this is what you said is also a result of the metrics we are using to evaluate the performance of our food systems, right? So the food system is by design now optimized to maximize cost and maximize yield. And with the examples you gave are a great demonstration of a system that is capable of maximizing yield and minimizing cost, but at what cost? At what broader cost? At what societal cost? And what environmental cost that we're all paying as a society?
Yeah, and it's amazing that we are now starting to think, even as simple cardiologists like ourselves, started to think about these complex issues, right, outside what we are studying in the clinic and what we're seeing in clinic. I'm going to just take thank you, Basil and Sanjay, for the really fruitful discussion. I'm going to take a few minutes and kind of discuss Andrew Macker's paper, who, Andrew is joining us from Boston University, and he's written a paper with Dr. Barak Al-Ahmad at Harvard to link work and heat exposures in the 21st century. So welcome, Andrew, and could you please tell us a little bit about the mechanisms that link heat exposure, occupational heat exposure specifically, with increased cardiovascular disease prevalence and incidence?
Yeah, of course. Thank you so much for having me. So this was basically the main idea behind the paper. So workers in occupational settings often face heat exposures far beyond those encountered by the general population due to the combination of heavy labor, which requires a higher metabolic output, extended durations of exposure to high temperatures, and environmental factors such as global warming and insufficient cooling mechanisms, such as mandatory brakes or AC. So this heightened exposure leads to a greater cardiovascular burden, particularly for vulnerable populations such as older workers or those with pre-existing cardiovascular conditions. So there's 3 main mechanisms that we highlighted within the paper of cardiovascular strain between occupational heat exposure and increased morbidity and mortality rates. So the first one is increased heat stress and core temperature regulation. So the body's effort to maintain a normal core temperature under heat stress requires significant physiological adjustments, including elevated heart rate and increased blood flow to the skin for cooling. So this redistribution of blood flow can strain the cardiovascular system, especially in individuals with pre-existing health conditions. So another mechanism is actually the worsening of these pre-existing conditions. So as the workforce is aging, so are the levels of comorbidities seen in these workers. So for workers with underlying cardiovascular, metabolic, or respiratory disorders, heat exposure actually exacerbates their conditions. So pre-existing cardiovascular impairments such as reduced cardiac output or arterial stiffness, they actually make thermoregulation less efficient, and it amplifies this cardiovascular strain. So on top of these, the third mechanism is the emerging exposures in migrant workers specifically. So migrant workers often endure prolonged exposure to extreme heat due to their working conditions and limited access to protective measures. This demographic faces compounded risks from occupational heat and global warming, increasing the burden of their cardiovascular systems.
Yeah, thank you. I think there's a lot of emphasis now on ambient temperatures, and little has been we focus less and less on occupational heat exposures, but that's something that is extremely important, as you highlighted in your paper.
So I'd like to bring another possibly work-related factor. As you all know, the American Heart Association has now officially added stress to the number of risk factors that we consider important for coronary artery disease. And in the last 10 years, there's been some wonderful research done looking at all the pathways of stress, how in the hippocampus, we have the amygdala that senses stress and then processes the stress, sends signals to different parts of the body, including the bone marrow. I mean, all of these pathways are being elucidated very nicely and showing that clearly stress is one of the important factors that increase inflammation and eventually also increase atherosclerosis. So I can, when we hear statistics such as only 20% of the population enjoys their job, and the rest just work to make a living, clearly work environments have to be stressful. I mean, all we have to do is talk to our colleagues and our patients, and we hear a lot about that. So what as a society, is that a topic that is being looked at beyond just heat exposure, just conventional stress involved around the working place, and how that adds to the whole stress that society is now facing, including, wanting everything done yesterday? We deal with the telephone constantly asking us to get something done that was needed yesterday. How much all of this potentially is an important environmental factor in increasing heart disease?
Yeah, so that's actually a great point. So specifically, we focused on occupational heat exposure, but in the central figure, the main idea of the paper, the first topic we actually cover are the common workplace exposures. So that includes what you're talking about, stress. So the main common workplace exposures that are heavily researched in the literature are physical, ergonomics, chemical, biological, psychosocial. So all those together increase strain on heart, which does increase cardiovascular morbidity and mortality. And then to compound on top of, like you were saying, stress, these vulnerable populations that I was talking about, such as migrant workers, they're facing compounded risks, such as increased level exposure due to, not enough regulation on how they're dealing with this increased level of heat stress and strain.
Fantastic. Thanks, Andrew. I'm going to turn it around to Dr. Maddock, who's a Regents Professor at Texas A&M, and he's the Director for Center of Health and Nature. And his focus has been primarily on access to nature and parks, and he contributed to the paper Green Streets, Healthy Hearts, exploring the roles of urban nature and walkability amidst the Exposome. So Dr. Maddock, thank you for joining us. Maybe you can tell us a little bit on a positive note. We've spoken about the bad things, air pollution, bad food, and heat exposure. But maybe you can tell us about what are some of the ways where the environment can be the solution, not just the problem. And maybe you can tell us about how access to green space and nature can modulate but also improve cardiovascular health within the context of poor exposures that we experience.
Yeah, thank you, Dr. Alkindi. And I think being an environmental health department, working on nature is the positive part of this whole thing, which really makes me happy. Really, you can think of multiple different ways that nature improves health. The first one is through improving the environment. And so by putting more trees into urban areas, we addressed the first speaker. It actually reduces PM 2.5 in the air, right? So we can actually clean the air that we work on. The other thing with the last speaker, it reduces heat. So we can reduce the effect of heat islands by increasing green space in neighborhoods. And just to touch on the other one, community gardens and food forests are another way that we can bring fresh local produce into urban environments. So you see that kind of direct effect of making really a cleaner, more sustainable environment through nature. The second way is really through physical activity. So both green and blue spaces, so water spaces and parks and like, increase physical activity. So people that live near these areas tend to be more physically active. You tend to walk more in parks and other areas and get in all sort of areas around blue spaces. And so we see that increase in physical activity. And then the third way is this reduction in stress. And we just mentioned this, so it's perfect hitting every topic here. A study that just came out about 2 months ago put people into either walk in a green space or walk in an urban environment, and then captured their brain activity. And what they saw was a reduction in executive functioning among people that were in green space. And what this says is it actually allows our brain to turn off some of the vigilance and those type of things. And we've seen this, for about 20 years, this idea of attention restoration in green space. And so that seems now to actually have a brain linkage of reduction in executive function when we walk in green space. So really, you can see, stress, the direct effect of air pollution and heat, and increased physical activity. It's not surprising that people live in green spaces have a very significant reduction in cardiovascular risk and mortality.
Yeah, so I see, nature as part of a way to, maybe one of the questions that Dr. Quinones asked Dr. Rajagopalan previously is how do we, vaccine might be a solution, but this is potentially a natural vaccine for us, right? Natural therapy for all bad stuff that we're exposed to. So that's something that, with the work that you're leading. I wanted to ask you, in health in general, but also specifically in cardiovascular health, we experience significant disparities in risk of cardiovascular disease, outcomes of cardiovascular disease, and so on and so forth. To what degree you think that access is to nature or environmental injustice, which can really apply across the board from pollution to heat exposure in the work to food environment, but more specifically to you is really access to nature. To what degree does that play a role in increasing the disparities in cardiovascular disease, and how can we think of it as a solution to decrease disparities?
Yeah, I think that's an excellent point. There's something we talk about in a lot in our field called green gentrification. And what this really means is people like nature. They want to be near nature. They certainly want to be anywhere that's waterfront, right? Like you try to find a cheap place on the water, good luck. And so what happens is as some of these greening initiatives go through, that the price of homes around that area increases or the tax base increases and we price people out. And so that's been a really big thing, is it seems that nature tends to be more for people that have means. And so part of it is how do we green other parts of the city? How do we do infills with trees, et cetera? How do we make sure there's equitable park space in every city? And so there's a program by the Trust for Public Land that's a 10-minute walk that says every American should have a park within a 10-minute walk of their house. And I think that's a really great way to look at this justice issue. If you look historically, communities in America were redlined. This was areas where people of color were not allowed to get loans, and they ended up living in certain parts. So East Austin is a good example of a redlined community. And if you go today and map the trees in those communities, there's less mature trees in previously redlined communities. And so historically, minority communities in America often have less trees. And so I think being really purposeful and going back to that first question on policy is getting trees in these neighborhoods to make sure they're not there. And then historical racism it also plays a large presence in nature. And as I'm actually at a conference today, and former U.S. Park Service directors here, and he said he was talking to one of his African American colleagues, and he said he told him that this was not a safe place. We often didn't go into the woods on our own volition, and bad things happened there when we did. And so there's this still feeling of lack of safety and of racism in a lot of natural spaces in America. So that's something that we're going to need to tackle if we're going to look at equity in this issue.
Yeah, fantastic. And I think the point that you mentioned about green gentrification really goes back to this concept of systems, right? And sometimes what's intended to be good ends up being bad, and it can worsen health, and can worsen societal justice, and so on and so forth. So what do you think about, if you can tell us about urban design, maybe just briefly for the sake of time, what is the impact of urban design in general, and how can we, on health, and how can we think about urban design from the context of health, from the lens of health? Are there any mechanisms to think about that? Can we bring in people who are urban designers with health, scientists, specialists, and so on and so forth, together in a room and have them speak, or how does that work?
Yeah, I think you're seeing a lot of this move into the design community. The recognition that people love nature and that are healthier in nature. So you're starting to see more of these green solutions. In the city of Houston, they're looking at something called bioswales. And so this is taking kind of areas that were normally concreted to get the water out during a flood event and ripping that out and then planting native plants. And these act as flood mitigation when we do have that issue, but then are bringing nature into these urban communities when we don't. And so really from an urban design prospect, it's really everywhere. The other great project in Houston is called the Bayou Greenways. And so we have all the bayous. City did a public-private partnership, $220 million to put trails, 150 miles of trails along the bayou so that there's access to green space, and then there's flood mitigation when we need it. So I think that dual use, that lens on our cities and how do we design cities to promote nature access and physical activity, and to try to reduce the cars and the pollutants and everything else that are coming in.
Fantastic. Now we're going to be asking a few questions for all the panelists, and maybe we'll go back to the question that I asked you, Jay, about this environmental injustice, environmental racism issue, and go back to Dr. Rajagopalan and ask him about what do you think about how do we contextualize PM exposure, air pollution exposure, and environmental exposures in general from a context, from the lens of disparities, injustice, racism, and how can we use that as an information maybe for risk assessment? How do you envision doing all sorts of things that can help us move forward?
Oh, great question, and I enjoyed Jay's comments very much because ultimately, if you look at it from the perspective of solving the biggest problems in society right now, we really have to start with examining what's going on with the most underserved communities. And many people who are very passionate about climate change mitigation often very strongly believe that by starting with the most disadvantaged, at the most risk for climate change, for instance, or for that matter, at the most risk for exposures, environmental exposures, that's where you start, right? If you want to solve the problem for the rest of humanity, you start with the people that are most affected. So in that regard, underserved communities and communities in the United States, we talked about red line communities, which really present an enormous challenge in terms of a conglomeration of exposures that happen. There's a whole range of things that are happening, right? Everything from all the systems that we talked about are awry at these places. By focusing the attention on rectifying some of these, by building environments that are more sustainable, that are more equitable, those would be durable solutions to reduce exposures in these communities. And by doing so, you're going to solve the problem for the rest of the communities, right? So there's a lot to be said about focusing our attention on the most inequitable, at the highest risk for climate exposures and environmental exposures.
Thank you. Bassett, do you want to maybe comment on, how do you view disparities, redlining, and, in general, the health gap or the disease gap that we see in the United States today from the context of food, food environment, food choices and environment, but also how do we solve that issue? And obviously it's a complex issue beyond, an hour of our time, but maybe you can just comment on what your vision is and how you view the issue.
Yeah, certainly. Looking at this from a food desert perspective or lens, especially in the U.S., there are many areas across the country where one would need to travel for more than 20 minutes to get to a grocery store to buy fresh fruits and vegetables, and anything that is accessible to them nearby is basically highly ultra processed food that certainly has an impact on health outcomes. And one of the things we could start doing is could be as simple as introducing more fresh foods at these points that and at an affordable price that is comparable to those of the ultra processed food. And the broader question is to how to make the ultra processed food actually or the healthier foods cheaper than the ultra processed food, because of the hidden cost that we are paying as a society of the ultra processed food that is not necessarily reflected in the dollar price we see at the counter. So again, it takes intervention at different levels, at the stores, making available more options, healthier options for people, but also looking at it from a more the system itself, and ensuring that we are incentivizing and supporting the production of cheaper, healthier food in general.
Yeah.
So everything we've been hearing tonight and a lot more that is in this journal for all of you to read, number one is clearly teaching us the degree of the problem and the magnitude of the problem. We're also hearing that most of the solutions are not going to be in a pill, but it's going to be solutions that require society changes, policy changes, government changes, and so on. And sometimes as physicians, we go, oh my, this is way beyond my capacity. This is really, we need to start doing other things. So my question to each of you to comment is, what do you advise the individual physician when I am with a patient, with all the knowledge that we have acquired and the complexity of the problem? What can we do individually with a patient in terms of trying to start making an impact in changing some of these things? Because a lot of the other changes are way beyond patient-doctor interaction in an office. It's more of a global society involving all the medical societies, our lobbying, and so on. What can I do sitting in front of a patient? And all of you are welcome to comment.
Good question. Maybe I'll go first and then allow my colleagues to comment as well. I think the first thing I would say is, look, we are now at a very important phase in sort of human development, and with incredible challenges for the environment, for human health, and sustainability in the future. It's looking at us right now. So the one thing that hasn't happened, I guess you asked a question of what would you tell a patient? Well, I would think that some of the exposures that we take for granted right now, we spoke about dietary exposures, we spoke about, which is a massive environmental exposure, if you think about it. Physical activity in accessible environments and air pollution are not problems that we shouldn't be talking to our patients about. We should be talking to them about it. So we already are doing this as part of it's not widely acknowledged as an environmental exposure, but we're already doing that. In environments that are exposed to high levels of air pollution, it is very much worthwhile a conversation with your patients. And hopefully in the future, we'll have artificial intelligence tools to tell us which one of our patients, based on their history, are at inordinate risk for chemical exposures, for instance, living in certain environments, or occupational exposures. Hopefully that'll happen naturally in the background, because there's a lot of things that we do as physicians that take time. And hopefully AI and new tools will allow us to sub-select patients who might be at high risk for certain types of environmental exposure. The other aspect that physicians ought to play a role, which is unfortunately been absent in the scene altogether, is to be vociferous spokespeople for environmental regulation, given the outsized effect of the environment in human health. And physicians have not been on the table. This often decisions in counties and cities and states are often relegated to policy pushers who have no experience in health, who have absolutely no idea. So when we talk about health in all policies, it's exactly that. We physicians need to be at the table talking to our politicians and leading the charge in terms of saying, look, guys, this isn't about politics. Okay, this is about doing the right thing for your people, and we have to be at the table with those decisions. So we, as a health system, have to sort out ways in which it becomes important, and physicians' times are compensated for these types of activities, and we honor these commitments, and that's an important role that we ought to be playing, which we are currently not.
Good, yeah.
And I would add just to that, I think there are two components here, and not necessarily going to the Congress and speaking as a physician, but really within our environment, right? As hospitals that are contributing adversely to the environments around us. So healthcare sustainability, environmental sustainability within healthcare is becoming something that is really, advancing the field forward and contributing to the health of our environment, which ultimately will impact our health. So that's something that we don't necessarily think about all the time, but that's, we have to start to think about it.
Good. Any other thoughts?
Yeah, real quickly, you can prescribe nature. And so Occupational is one of our partners. You can go there.
I like that,
and they
prescribe
have all the
nature.
materials. And you got to get the nature piece in, of course, but a great way to improve health and something that any physician can do. It's free. There's trainings online, and your patients can actually go through the portal and get their prescription. So a quick way to kind of do something that's actionable tomorrow.
We like that, yes.
Love that.
One last idea also is to do more of these dialogues between different disciplines, because it's clear with all of this complexity that we see that no one research discipline or no one area of expertise will be able to address all of this complexity. So I think every one of us today is leaving a bit more inspired and learned something new from the other speakers and from the other studies, which they wouldn't necessarily read or hear about as part of their disciplinary expertise. So I think more of these platforms and dialogues are very important. So thank you for doing that.
One final, we have only a couple of minutes left. One final question to you all. As cardiologists, we are so embedded in this concept of randomized clinical trials. We don't believe anything unless it was proven by a randomized clinical trial. In this topic, which is so complex, is there potentially any room for some prospective trial research that would enlighten more in how we can improve things? Or this is just something that will always be observational in terms of the research?
No, I think there's fantastic opportunities. I think the future of environmental clinical trials, if you will, are incredible opportunities in urban design. There are various design interventions that could be done at scale. In huge neighborhoods, there are new cities that are being designed, and that's a natural experiment for you to observe what happens to human health. Right? You can, my good colleague Dr. Aruni Bhatnagar is doing a fantastic green heart intervention where he's planting 500,000 trees in Louisville, Kentucky, and looking at the impact of health for not just a few years, but over decades, like the next Framingham, right? So there's going to be incredible opportunities similarly in agricultural intervention, let's say, where you change thousands of acres and biodiversify and look at the environmental impact on the communities that the lands, subserve. So I think we just have to switch our brains and think about things differently. And I think there's tremendous opportunity in innovation and ways of reimagining the future of health.
Well, that is fantastic. And on that note, we are going to thank all of you for participating. And we thank the audience for participating. And this, of course, stays in our educational channel so people can afterwards come back and also visit with us. So thank you, everybody. And good night to all of you who are our audience.
Thank you.
Thank you very much. You take care. Bye-bye.
Thank you.